And JJ, I am pleased to see, and this is a lack of proper coordination on my part. Dr. Anna Perez is a PhD social work, and she has joined the conversation at like exactly the right time I'm seeing her. So, Anna, if you don't mind, just do a brief introduction, and if you've got any thoughts so far on the conversation. Sorry to put you on the spot, but this is a very informal town hall. So love to hear your background and your thoughts on what you've heard so far and your perspective on how social work is going for you and how things are in this era.
Thank you. So quick background, I currently work at two hospitals right now. I work both in acute care and the emergency room. I got my doctor of social work from University of Southern California. Right on. Anyway, so I'm a licensed clinical social worker, and I'm also a licensed chemical dependency counselor. So my focus, you mentioned about the opioid epidemic, that was actually my focus when I was doing my dissertation.
Yes.
Just my thoughts on everything. I think by nature it's been kind of hard. I have experienced where, the hospitals for a while were, it was the dip, or we did have a census dip. What I have seen though, the two hospitals that I work at serve in my city. I live in San Antonio, Texas. We're about 2 hours close to the border or whatever. We serve the lowest socioeconomic demographic. So many of the people we see are unfunded or they're underinsured. And I tell people you can have insurance, but you can also be underinsured. And we serve a lot of the homeless, and we serve a lot of immigration.
Yeah.
So I see this. My focus specifically is on addiction and trauma. And what I am seeing, and everything you guys were saying, I was listening and I was like, yes. Yes. Like enthusiastically, I was fangirling all of you. That we have seen this. I do go to some of these Zoom AA meetings and NA meetings, and I'm seeing a lot of people. We're talking about 10 plus years in recovery without having that social connection. We are seeing relapse. Yeah. I've been seeing it. It's very difficult. I've had these conversations with these people in the ER who are saying, doctor, I don't understand. I don't get it. I thought I was strong. And I'm like, well, it's not every day that you go through a global pandemic. It's not, Right. I don't think, I don't know if people didn't take this serious enough. I don't know, or we just didn't know, or people just didn't educate themselves, or the powers that be, like certain administrations, didn't put the information out there. I'm not trying to put my political bias in there, but anyway, but it's true. But it's true, right? But it's true. And I'm seeing a lot of relapsing. For what I have seen, at least, at least for my geographical location, I'm seeing a lot of relapse with the methamphetamine use. A lot of people that have not been able to get that in-person connection in regards to mental health, because not everybody's gone telehealth. I think telehealth might be the way of the future, but not everybody's done it. So for a lot of these people to go and start that, to have that interruption services, I'm seeing it. It's caused a lot of family disruption, because for a lot of these people, when they relapse, there's other biopsychosocial factors that will play into that. Now you get involvement with law enforcement. Now you get involvement with child protective services, things of that nature. And therefore it's causing family separation. A lot of people are not considering that. Of course, then you had job loss. And this has caused people to just panic. To that note, I've had several patients, one in particular that I can think of, that he had a job, but he was freaking out because people were not taking the social distancing seriously. So he had a mental decompensation happen with him where he quit his job. he was no longer talking with his family. It was so bizarre to see him absolutely just decompensate, and it was very sad. And again, he went from being employed to now not being employed because he just had so much fear. A lot of my patients who have anxiety disorders already, it's just I've seen people just really regress and decompensate. It's very sad. So that's what I have been seeing. And then from a case management perspective, it's very hard because we don't have the manpower for some of these resources. So in San Antonio, we experienced where the homeless shelters were no longer taking patients. So when we need to discharge them, where do we go? We don't even have shelters to put them in. So it's just impacted us in ways that I could never have predicted.
Yeah.
It's also impacted some of our providers as well. We have actually had patients that are living in skilled nursing facilities that have said that the hospice providers are not willing to go into a skilled nursing facility because they find out there's some COVID positive patients, and it's just the domino effect. I have no words.
Okay, so I have some comments on what you just said, but so I'm going to try to get these 3 points out as quickly. One, a couple of weeks ago, I posted that I have the most brilliant and beautiful friends on Facebook, and I submit Exhibit A, Dr. Perez and Dr. Racina. So thank you for joining us and giving your perspective on that. I think what I want to synthesize with what JJ has said and what you have said now is that we really have failed. Okay, and it's not. It is so evident, and now we have to re-engineer our approach. But we have now we're gathering the evidence on our failures through these conversations. There are conduits to get these the pearls out of these conversations to people that can perhaps act on them. So John and I are that conduit. I think we're going to try to do our best to be that conduit. So that was my second thought. My third thought is, and I'm going to try to be controversial here because of the voices that we've heard so far, like John and others that have emailed me and friends who have said, when is this going to get back to normal? Like JJ said, well, what do you define as normal? But ultimately people are trying to understand two things. One, did we overreact, or did we overreact in a way that was a blanket and instead of providing some sort of targeted containment and way of dealing with this? That's one question. Did we overreact? Because by doing what we did, we have put people who were at risk, that you just described, at even greater risk. Okay, so that's one point of evidence, and one question that I will pose to JJ and you: did we overreact, or did we inappropriately react? I think JJ covered that we most definitely inappropriately did, but overreact is the question that I'm getting. And then the second question would be, at the nexus of social work and the evidence that Anna just provided in her experience so far, and therapy and psychiatry, besides the enormous stress put on these people that Anna just described socioeconomically, what else is there that we can do? Is there a strategy for suicide prevention in these types of communities, for providing support for these, for what you just heard described? JJ, I'll let you go first.
As I listened to what Anna said, the association that I had is to think about expanding one of the core principles and key insights from the recovery community. And that is that one of the things that's emphasized in many programs is the problem that in order to break a cycle of addiction, one needs to modify the routines of life that help to perpetuate it. One of the mantras in some of the 12-step programs is this notion of people, places, and things. The idea that there are people that we spend our time with, there are places that we go, and there are things that we do that are tied to the addictive behavior that keep us in close proximity to the temptations to do it and the reinforcement of it. And if we're going to actually break out of that, we need to replace it with something else. And so there's a corollary to that insight, and it's a simpler one, and that's this problem. Nature abhors a vacuum. So why do I highlight that? Because most of the response to the explosion of the pandemic problem and what we have said that people need to do is basically equating to telling them, don't do X, fill in the blank. Don't do X. Don't do this. Don't go out. Don't go to work. Don't get close to each other. Don't touch each other. Don't, right? But we did not say do, and fill in blanks for do. And I see Anna nodding because that's one of the critical things that we do in the addiction, in the addiction and recovery community. We don't just say, don't drink. Are you kidding me? People heard don't drink 50,000 times from all the people in their lives before they ever finally came to treatment. If knowing that it wasn't a really healthy thing to overuse substances was enough to break it, we wouldn't have a job, right? So don't do is not helpful. And so what we need to be thinking about is, please don't do this. Please do this instead. There needs to be an instead, and the instead needs to be in the direction of health. Positive for the individual who takes it on himself, and positive in the service of the other people in that person's lives. And that's why also the recovery community emphasizes service once people have sort of shored up their own individual foundation. And those are really a lot of the things that we're lacking in our response. I do think that dovetails to your question about whether or not we could have a suicide prevention initiative. But it does boil down to the fact that not everybody is wired the same way. Not everyone who ends their own lives or is at risk to do so has the same pathway to that endpoint. There are statistics, and we can come up with numbers about how many people die by their own hand within a given community in a given year. And I got to tell you, there's always been this urge or drive or desire to design studies and come up with initiatives that are the thing to do to prevent all of the suicides. In fact, so this is a place where, despite the fact that I had all those years learning from and working within and working for the government, there's one thing about the government's approach here that drives me up the wall. They've called their suicide prevention initiative the Zero Suicide Initiative.
Yeah.
And that is a setup for failure right from the beginning, because we will not ever stop everyone from ending their own lives. In fact, we actually have a pretty robust ethical backing for the idea that some people should be supported in their desire to shorten their own lives artificially because they are suffering, because it is justified to ask a physician to assist. We don't need to get into a debate about physician-assisted death here, but my point is that saying that our goal should be zero suicides is a setup for failure right from the beginning. And more importantly, it's this idea that all the suicides are the same, and we need to go from whatever the number is to zero by doing one thing.
Yeah.
This is the place where we need to embrace human difference, not sameness, and realize that some people are at risk of ending their own lives if they feel overwhelmingly panicked by the possibility of getting a COVID infection, like the gentleman I talked about before who killed himself in our hospital. But that's not the determining factor for suicide risk for somebody else. For somebody else, it might be me if I feel shameful that I let down a patient and allowed them to die when I could have saved them. And I feel so bad about it that I don't feel like I deserve to live. So that's what's going to end my life. It isn't panic, it's shame. For other people, it's rage without an appropriate target. Some people are so furious about this terrible situation that we're all in, so upset about it, so angry, but they also have a really strong conscience and they know that they really shouldn't kill anybody else. And the only target that's available to them is themselves. And so in this insidiously, psychologically terrible way, the person they attack is the person they see in the mirror, even though their goal isn't really to be dead. And so you see, if we're going to be helpful, we need to recognize that there are different determinants for different people about what gets them in trouble. And so that's why I would advise that what we do is we tie our COVID test records to a public health initiative that starts first and foremost with reaching out and asking questions, not pointing at people, not telling them more what to do, not directing them places, and not forcing them to have resources that we think should be good for everybody. This will be good for you, do yoga. This will be good for you, learn mindfulness. This will be good for you, go get exercise. This will be good for you, eat tofu instead of beef. Like, how about you got a COVID positive test? How are you doing now? Talk to me about how your life is different now as compared to what it was before you were told what you needed to do. Are you having any challenges meeting the demands of what people asked you to do after you isolated? What are the things that you can't do for yourself now that you always were used to doing and now they were taken from you? Questions, not answers, because the real solution for each individual comes from within her own experience, not imposed from the outside by somebody else who's an expert. And I'm supposed to be a suicide expert, and I'm telling you I am not the expert in what saves individual people from suicides. It's the people who are actually at risk and on that walk who need a reflection with somebody else who can guide them to their own way out, not somebody telling them what to do and just throwing something at them that should be a one-size-fits-all resources that fixes it. So this is the embracing sameness and difference dynamic tension that I think really, that's my favorite thing that came into my mind just by being here tonight with you, because it's just, it comes up over and over as I think about what we need to do.
Yeah, outstanding. Okay, so here is the scenario. I think we've had a couple of comments from my friends and the guys have been with us from like the beginning, like Jeff and Terry. So I want to open the floor to see if they have any comments, because I know Terry said that the first year is very important in sobriety, and if he has any thoughts he wants to share, I'd love to open it to Terry and then also to Jeff, and then I also see Lauren is here, and then we'll take it back to Anna if she's still available. I will not yell at her for Zooming while driving. She is in San Antonio and all the roads are straight and flat. So, but I'm so glad she was able to join it. Clearly she was between some engagements, but all right, Terry, go ahead if you're there.
No, I'm saying Zoom meetings are such a poor replacement for what's actually needed. Someone new to recovery, it's you take the connection away when they need it the most. You're putting them under the most pressure to go back out. It's as simple as that. Success in the beginning, if you're going to recovery through a 12-step meeting, is having that inclusion. You're coming out of a period of your life where you're emotionally stunted, intellectually stunted, all these other things. You need people of like minds to help you through that. And that connection is not, you're not going to get that through a Zoom meeting. They're kind of a farce to me.
Yeah, absolutely. Now, do you know, or have you heard anything about in your community whether there are people that are struggling because of being, isolated at home? Anything that
Yes, a lot, a lot. The majority of the newer people, and I don't know with what Dr. Anna said, that someone of 10 years relapse going through this.
Yeah.
To me, that's a foundation issue. That isn't a pandemic issue to me.
Okay.
You know what I mean? At 10 years sober, you should have a little bit more feet under you, that you're not, I have a long time at the tables, a long time at the tables. So someone 2 years and under, I could see where the sudden vacuum where they've been counting on the personal connection is suddenly gone. I can understand that. Maybe not 10 years, but I'm not everybody. So, I can't address that. I don't know the person.
Yeah, clearly.
Yes, I am.
Did you have any questions?
I wanted to just mention, we always call it social distancing.
Yeah.
I think we should call it physical distancing.
Here,
Because
here.
we need,
That's wonderful. I've been saying that for so long. Thank you for that. Keep going. Go, go, go. Go. That's great.
we need the social closeness now, and more than ever. So, yeah, and then the other thing I wanted to mention, you're talking about availability of alcohol. I'm a medical cannabis user. I live in Illinois, and cannabis has been, medical cannabis program here has been legal for about 6 years. And I've had my license for, I don't know, 4 years now. But we just went recreational in January. And now all of the dispensaries in the area are closed down. And there's a lot of people that really need that medicine, and it is medicine. I use it because I have a myopathy, a muscle disease, and it helps me with pain and the ability to sleep. So I'm just kind of wondering about them and hoping that those people will be okay.
Because access has been curtailed, right, Laureen? Right? Yeah. Yeah. That's very difficult.
Yeah. Karen, do you have a question?
Yeah, Cindy is indicating that she has a question. I think it might be a little too long for her to write it in the chat.
No,
so
please. Yeah, let's hear it. Absolutely.
we're gonna have her unmute herself and ask it.
Okay.
Take it away, Cindy.
Okay, thanks. Can you hear me okay?
Yeah.
Yeah, because I've got headphones on because my speakers are good. I guess it's more comment than question. At the beginning of this, there was a statement to the effect that we had a pandemic plan left by the prior administration, and it was discarded by the current administration. I don't know what was in that plan, but it sounds like going forward, there should be a mental health component as well as a physical health component, because both types of health are affected and need to be addressed. I guess that's what I had to say.
That's awesome. So I will post the 59-page playbook on the research group that I have. Of course I have it. You know I have it. So I'll post that. But JJ, comment on, absolutely. So there is a physical health plan, and there must be. You're right.
Very nice. Absolutely. Well, yes. I mean, it's like building a machine and asking it to then serve you and do its function without fuel. If you're going to say, I have this great plan, I will build what is necessary to endure this pandemic, but then I won't fuel it, because what fuels us, of course, it's our desire to survive. It's our humanity. It's the meaning of our lives. And if you don't account for those and you just say, well, as long as you're alive, that'll be okay. Well, not really, actually. If you have no job, no prospects to keep the flow of food into your house, no way to be connected to things that are meaningful to you, then there's that logical, obvious question in all of our minds: what are we living for? What's worth trying to fight to survive for? So you're right. That has got to go hand in hand with it, because otherwise it's a bridge to nowhere. It's not surviving for any purpose, right? Good stuff.